Hi, everyone. Just for those that don't know me yet, like as Fred said, I'm Richard Langford from Jimmy Health Systems. I did some initial presentations, I think it was on day one, with regards to fire structure maps and just thinking about some of the mapping challenges and some of the technologies and tooling that do support data mapping. So if you're like me that ate way too much, we're going to try to wake everyone up. So what we're going to be doing is we're going to be going through a couple of slides, myself and Niels, and then we're going to have, as Fred said, a little discussion a little bit later on. We would like to hear from you, the community. What are your challenges? And as a community, help try to address and talk to some of these challenges. But as a starting point, we've heard a lot about standards and interoperability, standards on its own, tying this all together. What does this all really mean? So I've got a couple of high-level pictures to really help kind of solidify some of the great kind of conversations we're having over the past 2 or 3 days. But first of all, when we start thinking about a health information exchange, I'm going to get a mic out. Who would like to share their opinion on what is a health information exchange? Who would like to talk to that in their own opinion? You could reflect on something that you're doing at the moment, based on something you've heard, based on something you've read, but what is a health information exchange? I'm going to walk around with the mic. Anyone?
Yeah, thanks.
Hello, thank you. What comes to my mind when I think of HIE, I'm thinking of a data highway through which multiple systems transact data. Thank you.
Correct. Thanks very much. Would anyone else like to add to that? I know my slide's on the screen, but I would like to hear your own opinion, Okay, great. So here's something that I've kind of put together. This is just my own opinion, my own wording. I'll just quote exactly as I've said it. It is a popular and ever-evolving methodology for enabling the sharing of personal health information for continuity of care is to establish a health information exchange architecture which, through the incorporation of industry-recognized standards-based frameworks such as HL7 FHIR for seamless system-to-system data exchange, will improve service delivery and overall quality of care. And we will learn a little bit more about standards as we move along in this presentation. An HIE is a central architecture that is responsible for the secure storing and sharing of that personal health information. Not on its own, there will be some configuration, of course, important policies to put into place, driven by regulatory, but that's the overall intent of health information exchange. And interoperability is essential for enabling the seamless sharing of integration of health information exchange between systems. Very importantly. And I would like to just briefly talk to the open HIE architecture, just to kind of set awareness. I don't know how many there are of you in this room that are members of the open HIE community. I know some of us did attend the open HIE community conference in Sri Lanka recently. Just to kind of set some awareness, so you can see a basic architectural approach, which kind of lends itself towards some sort of standards-based kind of considerations as you start thinking about open HIE. Niels is going to talk to IHE profiles a little bit later, and we start thinking about your exchange standards side of things, and some of the profiles introduce some of that as well. So what should you be doing when you're talking to various registries? What data should be passed? What data should you be getting back? And the order in which these events are actually fired. But I'm not going to talk into that into detail now. Niels will be talking to that a little bit later. And then you can also start thinking about your registries. What data do you first of all want to store? Where do you want to store it? And how do you actually want to use it? Here we can see we've got a shared health record. So that's your de-identified personal health information that's associated with the patient, so the clinical information. It's important to ensure that information is de-identified for obvious reasons. Then you can have your client registry. Your client registry is where you will store the personal information about the patient, basically the administrative information, the personal identifiers, that is like your business identifiers, medical record numbers, and, national IDs, and so on and so forth, that can associate the patient then later on with the clinical information in the shared health record. Not directly using business identifiers, but through other sorts of ways, maybe private keys, encryption, whatever. There are other ways of identifying the patient. Then you have your other general registries like your healthcare worker registry, your terminology services, of course, But I also added a link on the bottom right here. So if you want to learn more about this open HE architecture, please feel free to click on the link and you can get a strong understanding of the documentation around how this architecture was put together and the role that each of these registries play. So challenges facing health information exchange. Now this is where I think we've had a lot of discussion around this over the past few days. Who would like to talk to, well, first of all, what, in your opinion, what are the greatest challenges facing health information exchange in your context? Might be something that you're working on at the moment, something that you've been facing in your country for quite some time. You're still trying to figure out how you can put this together. But what are the challenges facing your health information exchange right now? I would love to hear from you. Something that's quite popular, of course, we know about the messages, the data elements in these messages, the varying format of these messages between different systems, but who would like to reflect on that? Maybe talk about a system or maybe talk to some of those pains and maybe some of the approaches you've taken so far.
Is there anyone in their country works with the HIE kind of framework, if you like?
I forgot, Fred, we need to go like this. Who's all implementers in this room? There we go. This guy with the orange shirt. Ask him. Give him the mic.
Come on, Francis.
Yeah, my name is Francis. So I've tried to work specifically with the OpenHIE mediator and the instant OpenHIE. I think from infrastructure perspective, the mediator works. Instant doesn't, and is seemingly no longer supported for some reason. But one of the things that I've seen is it gives you like just an interface or a template where you can map your original system data format and then now use it to convert it to FHIR. But is there a way, is instead of having a very complex infrastructure, in my thinking, actually the mediator is much better suited than instance because it gives you other additional things like Iris and other systems to manage other workflows, which is okay, but I think specifically for interoperability, are we looking at interoperability from the point of view of sharing data around healthcare organization and management, or are we looking at data from the point of view of clinical care? I'm not sure whether there is a dotted line that joins the two. And then the other question I have is in terms of like, as much as yes, we are trying to push a framework for interoperability, how do we come in to maintain it? Because I know the other one is dead, but what is the future moving forward? If it's going to be open source, how do you make sure that it's sustainable? And if it's going to be quote unquote a closed source solution, how do you make sure that it also takes care of the clinical workflow as the major use case that it addresses? Over.
Yeah, thanks. Those are very interesting questions. And I think some of it might be answered by Neil's presentation a little bit later. But thinking about what data gets shared with who at what points in time, that's your use case, right? That's also driven by your policies, but that's by your regulatory. We can't decide, what data will be shared with who. What do your policies say and what are your use case requirements? Do you need to have data shared with specific providers at specific organizations as a whole? We spoke very briefly in the previous session, actually, you start thinking about consent. So, which is another critical topic. So we might have some sort of regulatory that says at a high level, yes, you can have data shared from one organization to another, or specific data from specific organization with another organization. But then what does the consent say from a patient's point of view? So from a functional point of view, an organization could have access or an individual could have access, but if a patient says, no, you will not have the access to this information, then obviously that's another layer added to the complexities that you just kind of spoke about. And then when you start thinking about in terms of managing interoperability, yes, OpenHIM as one such tool is open source. It's driven by the community. I don't think we can really solve every single problem by ourselves. We do need to have implementations, contributions made. It's kind of difficult to provide, I suppose, direct, dedicated support at all times. Just obviously funding is a critical component. But we do actually have, just in the context of OpenHIM, we do have some package. I don't know any details about the package to try to say we can offer a dedicated SLA for your support to help you with your interoperability requirements. But for the most part, like most of the open source tooling is driven by the community. The more contributions we have, the more feedback we have, that's what strengthens the tools and gives it better kind of quality and kind of scaling, I think, in implementations. I don't know if I answered your questions. Okay. Would anyone else like to add to that? Fred, can you pass the mic there, please?
Thank you. My name is Samuel from Electronic Labs. So one of the other challenges I would point to is the aspect on identification, unique identification, to be specific. I know for the case for Kenya, it's been, since 2014, there's been lots and lots of efforts just to uniquely identify a patient. And as late as last year, there was still another shift to another system for identification of patients, because part of the existing national identification documents are not cutting across all population. And so there's been always the question of what's that one number then do we pick that speaks to each and every citizen, including children as well as adults. And thinking about the shared health record, then you must get it right as far as the unique identification is concerned, just so that there's that continuity of care. Thank you.
100%. That's a good question. So identifiers is another type of standard that a country needs to think about. And when you start thinking about maybe something like a national ID, most countries issue a national ID from a certain age. Typically from the ages of 15 or 16, I believe, you get a national identification number. So just to rely on a national ID alone might not necessarily be enough, right, for children or adults younger than the ages of 15 or younger than the ages of 16. So it's that. Do you start thinking about identifiers that if you consolidate them together can help re-identify a patient from a standards point of view? Of course, are you using a client registry? Are you thinking about using a client registry at the moment? Right. And how mature is a client registry right now? Is it actually working? Are you able to identify patients? Right. Yes, I think thinking about that is just literally going to be about trying to really standardize what are these identifiers going to look like. And then you can actually implement then your client registry as well. So as you using HIE profiles or using whatever mechanism you want, what you've deemed fit in your context, you can send this data into your health information exchange, take the specific parts for the patient information, stick into your client registry, including those national IDs, and then you can leverage that from a business perspective to help re-identify a patient. But you might get null data, you might get bad data, depending how it's captured, so you might not always be able to rely on that, which means you have to start thinking about more complex algorithms, the various algorithms that come with client registries. Fuzzy matching, for example. What if you can't find a patient using identifier? You have to rely on fuzzy, and you might get multiple patient matching coming back from that. Then you have to have some sort of process in place to say, right, usually a person sitting at the other end, okay, this is actually the patient record I want to work with. So yeah, there's an end user required, in this case the nurse or clinician of some sort, to help choose that record. Some instances you even think of automated linking. I'm not entirely sure I'm usually fond of that, but there are some really complex algorithms that have been implemented that can say, I know for a fact, based on some weight, 80% or 90% up, whatever the weight is, I know this is you, I will just automatically link your data. But I'm not a huge fan of that. I haven't seen too many implementations of that, and yeah, I don't know when I'll feel comfortable with something like that, to be honest. Does that help? Thank you.
Let's keep going.
Cool. Yep. Right, guys. So I think just looking at interoperability, I think we've got a good understanding, from some of these questions so far, what interoperability really is. Something that I have seen in a few contexts, I've mentioned in the previous session as well, that some organizations can even have point-to-point integrations, systems that are interoperable with each other. Like a local standard, whatever they've implemented, doesn't matter. They could have data transformations implemented in code on like your lab and EMR machines locally in the organization, fine. But you have point-to-point interoperability taking place. Now, you can also have interoperability from an HIE perspective when you want data shared outside of your organization, like I was saying a little bit earlier. So if you want to have data shared outside with your organization, with another organization or a lab, you start thinking about adopting HIE patterns, start thinking about HIE principles. So standards and interoperability, I'm just going to sum this up. As one organization trying to share information with another organization, that organization must actually understand what am I saying. Must be able to interpret the data the same way that I'm able to interpret this information. I can't force that organization to change what they have. They can't force me to change what I have. So we think about a standard, somewhere in the middle. What's going to help these two organizations talk to each other? I mean, for me, HL75 is probably the best, I think, standard out there to actually to implement something like this right now. It's the most current, how can I say, popular trend in the HIE community at the moment for the last several years. But you can also start thinking about things like HLCN version 2, HLCN version 3. There are other standards that do exist, but HLCN5 being the most popular one. And when you start thinking about standards, you've got structural standards, semantic standards, content standards. We're going to see shortly what structural and semantic standards really look like, as well as see some examples for content and transport standards. And as you can notice, I've specified identifier standards. It's also a type of standard, right? So some examples with regards to structural interoperability. So this picture I was trying to actually really show that we have two systems trying to communicate with each other. In this case, the EMR is sending a message to the lab system. In this particular structure of this message, I'm saying patient.first name, okay? The lab system's saying, okay, well, I expect patient not given. So that means when this message reaches the lab system, is it going to be able to find information about the patient's first name? No, it's not, because it doesn't understand that data element, doesn't even know it even exists. It's not going to think about looking for that. It's completely unaware. So you're not going to be able to report on patient.given or even use it in the context of the system. Hence the sad face. And then when we start looking at semantics, we start looking at your terminologies, your vocabularies. So for example, in this message, you can see that we've got patient given, matching the patient.given in the other system. But then we look at the observation code in red. I can't remember what this code was for, to be honest, but this particular code over here is for HIV viral load. This system's trying to show that I'm only reporting on viral load examinations, and I'm expecting data, or at least lab orders that's been submitted, new lab orders, to have this particular code for HIV viral load. Now, what do you think is going to happen when a system who's just doing its own thing, right, is specifying a code for HIV viral load that's actually not appropriate? When that lab order reaches the system, and the system is trying to find all lab orders that are associated with HIV viral loads, they're not going to be able to find that information. It's going to skew your reporting as well. So when you start thinking about vocabularies, you can actually really give that data a single meaning between different systems. They can both understand what the data means by a single code. And then when you start looking at standard-based data exchange, you can see just kind of included a FHIE, just to kind of show what it does. So before the message gets sent to the lab system, it will first go through the FHIE server. The FHIE server's job is to make sure that the data that needs to be provided is provided, the codes that need to be provided have been provided, there's no funny business taking place. And if that message is looking good and FHIE agrees with it, it will then allow it to be sent off to the lab system, typically through HIE, in the context of HIE and interoperability. And what I also want to mention, when we start thinking about the HL75 framework, you also have what we call implementation guides. And I think implementation guide, I keep saying implementations as a plural, I don't know why. So we've spoken about implementation guide a few times, I think, over the past few days. But when you start thinking about an IG, implementation guide, it is your use case specific implementation of the FHIE specification. So maybe you want to have an implementation guide for HIV, for TB, COVID-19, just general purpose for immunizations. I mean, like the smart guidelines, for example, for immunizations. You can have a very specific implementation guide that solves a problem. The implementation guide basically is I'm not going to say extension, I've got a very special word for this. It's an additional layer of conformance applied to the base FHIE specification that allows you to apply specific constraints for your use case requirements. And then conformance and validations testing just comes to show that when messages are sent into your architectural, into your system, like your lab system, for example, but before it gets there, it's got to go through a file server. It will make sure that your data is appropriate. And this is typically defined by your data requirements. So your data requirements will inform what these constraints will need to look like. We'll see that a little bit later. So then why would you want to consider interoperability in a healthcare organization? I think we've seen this before, but it improves the quality of care and patient experience, increases healthcare efficiency, reduces the cost of care, mitigates physician burnout, and that's actually quite an important one. There's been lots of conversations with regards to IPS, for example, and people, well, not people, but implementers, countries and so forth, are saying, let's just take data and send it off. You can't just send all information, right? It's information overload. When the doctors see 20 years worth of encounters and observations, they're going to say, oh, this is just too much. This is not going to help me. I need very specific information, right? So be careful and be mindful of the data that you want to share. And of course, it protects patients' data security. So what we will see a little bit later, what we will talk to a little bit later is just some of the challenges facing your healthcare system. But before we do that, I will also offer an overview of some of the implementation challenges we've seen in some real-world settings, some do's, some don'ts. But before I do that, Niels will be offering a presentation. There is a slide that seems to have gone missing here. There's something else I want to show you. I don't know where that slide is. Just give me a moment. Don't know what happened to it, but I know it's in here, so I'll just jump to a different presentation. I'll just show it here quickly. Sorry guys, the internet's very slow. It'll be a few seconds. There we go. Getting there. That's busy loading. I'll try it again. I don't know where that slide went. Okay, at least I got the slide. Yes, sorry guys, it's a bit all funny because the page is not loading properly. So thinking about everything, we start talking about FHIE. We spoke about data dictionaries over the past few days, data requirements, implementation guide. Let's kind of just see this in a bit of a summary. When you're starting with FHIE, when you want to really kind of get into creating implementation guide to start with standards to solve some of your challenges, start with the data dictionary. And your data dictionary identifies the constraints to the base FHIE resources. We spoke about that in terms of an implementation guide. By doing this, you get profiles. A profile is basically saying you can take a specific resource, you can then go and add your specific data to it if you really need to through the use of extensions to give it more meaning, or you can change the cardinalities of those data elements. You can apply where appropriate. You can even provide specific vocabularies, right? And these profiles live in an implementation guide. The implementation guide can then be installed on the FHIE server or deployed to a FHIE server. So when your messages reaches the FHIE server, it can be validated for compliance. And here we can see we've got a validation component that just says the FHIE server will ensure whatever data is passed in is conformant with the implementation guide. Where is this data coming from? It's coming from the profile definitions which have been informed by your data dictionary. Thanks. That was just the last slide that I wanted to show everyone. Right, thanks. Are there any questions before we hand over to Niels?
So I'm trying to deduce from what I used to do in my heydays. I'm trying to liken the IG to the WSDL. Are they the same? Web service definition language, are they the same?
No, so implementation guide is an artifact of, well, I guess artifacts, I suppose. So an implementation guide is really a space where you can define your, if I can maybe show you very quickly, I think that might be easier. I'll just show you very briefly what an implementation guide looks like. Here's a WHO Smart Guideline for measles immunization. And you start looking at the artifacts, it's basically profiles that have been defined based on specific data requirements for how your exchange should handle, at least a file server should accept messages coming in from the servers that are participating in that data exchange. So it's basically the rules and constraints that systems essentially would need to be conformant with as they exchange information with the HIE.
So the file server is reading these constraints as
Correct.
plain text and it's enforcing them.
Well,
Sorry.
yeah, so basically the file server is actually able to read these rules and constraints per profile. It's computational. That's what's important about it. So what that means is I can't go to a specific profile or resource and say, I'm going to add any random data element just for the heck of it because I want to use it in this way. It might benefit my system. If you add a random element into this message, the file server will say, I don't know what this element is. We're looking at the patient resource. You added some arbitrary element. I don't know if it rejects it, I must be honest, or if it just ignores it. I think it rejects it. You get an operation outcome back that tells you this is not allowed. But it's a computational requirements. That's what sits in the implementation guide to each of these profiles. It was basically what your systems would need to be conformant with as they exchange information. But I can have a session with you after the session if you would like, and have some private chats to help you through this issue.
Sure, thanks.
Cool.
I want to get down to it.
Sure.
Okay, thanks. Last, yep.
So mine is more of looking for an advice rather than a question. I've done POCs on OpenHIE, and I just want to know if I'm integrating just two systems and it's one system pushing data to probably, a good example is what I've used before, DHIS2. I have my application in several countries, and these countries have DHIS2. So the easiest options for me has always been just to use the DHIS2 APIs and push data. If I get another system, probably an EMR that's in a facility, we always look at the APIs on how we can push the data. OpenHIE, for me, I've always thought is for large systems, probably more than 2 or 3 systems trying to exchange data, or even 4 systems pushing data to one system. So what would be your suggestion with this? Would you tell me to just, try an instance of OpenHIE and see how smooth this is compared to my, let me call it quote unquote, legacy integrations that I've been doing?
Yeah, I don't think it necessarily requires the total number of systems to inform if you need an HIE. For me, it's more around, do you need to have information shared? I mean, is the other system in your organization, in the same organization, or in a different organization? Sorry. Same organization. Sorry? So then, if you want to start sharing information from one organization to another, you would probably want to think about some central architecture to support this data exchange. You could, if you really wanted to, if you've got special infrastructure, VPNs or whatever the case is, established, we can have a direct integration with another system. You probably could get away with that if you really wanted to with some proprietary standard, as long as you can make sure both systems can understand each other, sure. But what is your roadmap and growth from that perspective? Where do you see that growing over the next few years? So I would probably say, think about this a bit more strategically and say, first of all, these systems are probably going to have 2 different data models, right? So if you start thinking about FHIR now already, you could use a FHIR facade at a national level, right? That says, okay, let's take this data coming in, transform it into a format that the other organization needs to start working with, and vice versa. So you can have to and from data transformations. Or if you want to start thinking about sharing information, this is where the HIE comes into place. Then you can start thinking about implementing a FHIR native server and potentially even a shared health record. Otherwise, you're going to have to rely, well, if you want to do push and pull separately for example, you can use a shelf record. But if you want to have direct integrations, then the push and pull might just be automated depending on how you use your system. So it all depends on your use case requirements, exchange requirements. It's a few factors to really think about there.
Okay, okay. Maybe one more question, and then we'll have plenty more time for discussion.
Thank you for the presentation. Mine is, let me just say, it's a follow-up question. So how would HIEs be applied when you want to transfer data peer-to-peer?
What do you mean by, do you mean from one HIE to another HIE?
No, from one system to another system.
That could be anything.
Okay, let me put it this way. So you have let's say we have a branch in Mombasa whose patient has come to Nairobi for care. So that patient needs their data sequestered from Mombasa to Nairobi at the point of care. How would a HIE handle that in real time?
I don't know. There's too many factors to think about there. Your infrastructure, your resources. I mean, like I spoke about VPNs, for example. I've heard of some organizations that establish VPNs over somewhat reliable internet to have this data exchanged directly with another organization. Some organizations do that. I haven't seen many of them. I only have seen one. I don't want to mention the country. But I don't know. That's difficult to answer. I mean, there's so many ways one can really think about that. Depends on the available resources. That's probably the most critical thing. And where do you see this going over the next few years? If you try to be restrictive and say, I'm only going to solve this particular problem without really having the vision 3 to 5 years from now, then you might have to, essentially waste, not waste money, but redo resources and start thinking about HE all over again. Okay. That's a difficult one.
Maybe we'll pick that up again in the discussion. Awesome. All right, thanks. Thanks, Richard.
Cool.
Hi, everyone. So my name is Nils, and I'll be doing the second presentation after lunch. I hope everyone is awake by now. I'll be talking about a few different things. It's really weird to hear yourself right in the back of the head. I'll be talking about testing. I'll be talking about IHE, and I know it's another acronym. It's similar to a lot of other ones. So I'll hopefully bring some clarity. I have a few slides. And so I run a company named Kai, based in Senegal. We do work in West Africa and some other parts, digital transformation. Background as a software engineer, but nowadays more budgets and slides, unfortunately. And this work was funded by GIZ and some private sector promotion money, which is quite important. And most of it was done in partnership with a company called VisuApps, which is based in Austria. And they've done a lot of work on national architectures for exchanging data based on open data standards. And especially, they rank very high in the IHE Connectathons, which are yearly events of testing, which I'll talk about a bit. So just to dive, if you travel about 6,000 kilometers westwards, you can get to Senegal. And Senegal is a Francophone African country. I think I always put this slide just to remember to people where we are, but there's one element that is particular, and it's somewhat similar to Kenya in a certain way, much smaller country, but we have also a quite active digital IT sector. So for Francophone Africa, Senegal and Ivory Coast are the places where the IT sectors are most mature, and this plays a role in our project. The challenge that we have in Senegal, like many other African countries, is that there is a lack of doctors. Very few specialists, mostly concentrated in the capital. And so there is a need for patients to get care, to transfer between different establishments. And unfortunately, today, the data doesn't follow them. It's all paper-based. And in some cases, it's a real hindrance to get good treatment, but it also adds costs. Treatments, tests are done several times when you change the hospital. And also, sometimes you have your family members who are going to the hospital the day after you left to pick up the results and the discharge papers. So what our project was, the government in Senegal has been wanting to do electronic medical records for a while. Their approach has not been really focused so far, and basically there's not a great understanding of how to do it. And the plans initially that were discussed is, like in a lot of countries, well, we only have like about 30 hospitals. Let's roll out one solution in all of them, and they'll all exchange data. One solution, one provider. And we know from many places that this approach usually fails, because ministries of health are not great at rolling out software, at training hospitals, and in a way, it's also a high-risk approach, because you put all your eggs in one basket, and what we saw in Senegal when we analyzed the context is there are hospital management solution providers. They've developed their own solutions. They've sold them to some hospitals, and so hospitals are using those solutions for a couple of years now. And those who are implementers in the room know how much it takes to get a hospital to use an electronic software. It's not just you install it and you run away. It's years and years of training, mentoring, dealing with adaptation of software maintenance, providing equipment, making sure that the data quality is accurate. So the objective of the project was really to demonstrate to the Ministry of Health and the government there is a better way of doing electronic medical records, and you can leverage some of the softwares that are already rolled out and that are already existing. But we need to make them work together. And none of those softwares were developed according to standards. Some of them used DICOM to talk to like some imaging equipment, scanners, and we'll talk a little bit about that. And so the goal of the project was to demonstrate and to use approaches from other places that worked, that demonstrated how do you have a group of vendors that get certified that can exchange data between each other into a national architecture. And so I'm going to have to take a few slides about what is IHE, integrating the health enterprise. It's a community that was established in the end of the 90s. It's a global community with branches, regional branches in North America, Europe, Asia, and increasingly also used in other places. And basically there's two big parts of it. The one part is identifying use cases, problems that need to be solved, and then identifying standards from a basket of existing standards and matching those use cases to standards and putting out recommendations that can be then tested and certified. And there's a governance process how this is done. It's all open and available online. It's very easy to join. And it leverages some of the standards very heavily that we're discussing here. So HL7, FHIR, all the modern profiles are FHIR-based. But there's others. Like Graham said yesterday, there's not only FHIR in the world. So DICOM for imaging. And I always like to tell people IHE is already in Africa. Like most of the scanners that are installed in hospitals are IHE compliant. They use DICOM. And unfortunately, usually they're only connected to one computer that's in the next room where the doctor is reviewing the imaging. But they could be, in theory, connected to like interoperable infrastructure or architecture. The part that I want to highlight here is at the bottom. Well, there's two parts. So there's the profiles, the integrations. In a way, you can think of them similar to the IGs in the FHIR world. It's constraints. Basically, you take Fire and you make more constraining limitations to be able to test whether a system is respecting the profile. And the way that the testing is done is using yearly connectathons. So those are big events, and I'm going to show some pictures where vendors are registering and they have to demonstrate that their software is compliant by testing to 3 systems, and then you can get a certification. And that certification is been recognized as very rigorous and structured. So in tendering processes in Europe, in the European Union now, they make reference to the IHE certifications for public procurement. So in a way, this is creating trust, and like governments or like someone who runs a hospital and has to select a software can understand that they are choosing a mature software because it's been certified and it's been tested in rigorous processes. And those connectathons take place in North America and Europe. There's been the third one, I think, in Latin America a few weeks ago, Asia as well. And those IHE connectathons have very specific requirements. I know the word has been used in a lot of different ways, connectathon, but those are really rigorous events where there is a very defined process. There's a software that's used to like register all the systems, and you have to declare in advance which test you're going to be running. You have to find software to test, and then basically all the data exchange is recorded using proxies to make sure that you have a base for a monitor who is an official position who will grant a certification based on reviewing the data exchanges. So it's, and one of the particularities of this community is it's the private software companies that came together and decided we need to show that we are able to exchange data with each other. It's not government that decided, okay, we need an instance to do testing and we're going to organize it. It's the providers. And it's usually been relatively small and medium-sized providers because they said that otherwise the big providers are going to be winning all the tenders and saying like, well, you just need our solution to enroll it out everywhere, and that's it. So it's in a way a bit similar to like how the internet works. You have multiple providers and all have different pieces that are using the same standards. And the last point is also to bridge to these discussions we've been having over the last days. Fire is very much part of IHE, so there is a collaboration. Many of the profiles that were established recently are based on Fire. And also OpenHIE and IHE collaborate, and I'm going to explain that a little bit later. So this is an example of one of the profile. I'm not going to go through the document. You can Google it. It looks very similar to the Fire profiles, and in a way, if you look at some of the documentation, it even tells you that it's based on certain Fire profiles. And for example, the PIX-M, the M stands for mobile, and it shows that this profile is based on Fire, is in order to like register patients, and it's when you have different systems that are publishing patient data and you want to reference it from another consumer system. And basically the idea is if you have made this certification, then I know that your system can be plugged into an architecture that needs to access information from other systems. And so on the right, you also see like there's the use case description with a diagram, tells you the steps. And in the testing process, that's exactly some of the tests that are being done, and they're all laid out on the website. So I talked a little bit about tenders, and yesterday, Richard was asking me, so what's the incentive for a software provider to get an IHE certification? And well, there's a couple, but this is probably the strongest one. If a vendor is operating in a market where IHE has been recognized. So this is the decision by the European Commission of the integration of IHE profiles for referencing in public procurement. And the example on the top right is then how it can look like on a procurement document. The profiles are being referenced, and this is the profiles that the software should support. And basically, if during the process they find out that the software is not supporting this profile, then you're not eligible for this tender, and you can't win it, or you will have less chance to be the winning product. And all the results of the testing processes are public, so they can be looked up on this page, Connectathon results. And there's also a product registries that shows which products are supporting which profiles. So this is an example from Austria, because we're talking about architectures, national architecture. Particularity of Austria is it's a federal system, so every region has their own patient registry. And those are like the ELGA domains, and then they communicate with each other, but with a central patient index. And then you have interfaces to the systems, which can be a hospital or medical doctor, that access the document. And it's run by a government-owned company. They run the infrastructure, but like all the software components are IHE compliant, and they've been selected through tendering processes. And so, for example, you have a citizen portal where you can consult your own data. And then every hospital has their own IHE compliant software that they purchased from the market. But they were only allowed to purchase one that's compliant with IHE, because IHE is the base for the architecture. And so we've heard a lot of examples yesterday also from Diego about Indonesia, for example, having 50 plus provider solutions, and they have their own country, Indonesia specific testing. And this is a great approach. But unfortunately, it doesn't scale beyond the border of your own country. So the advantage of going with an approach that's internationally recognized is that in a way you could purchase software that's been written somewhere else, or you could export the software that's been written in your country. And so it's really about the markets of vendors and solutions. Security is a big requirement, and there's like some profiles that I used to do that. So coming back to the Senegal project, so obviously we don't have a government agency that's running IHE in Senegal. But what we said is we have vendors, and we can mentor them, we can train them to use open standards and use some of the IHE methodology to demonstrate that you have vendors that are able to get a certification at international level. And basically went through a process of mentoring. So VisuApps did that, a company I mentioned. And it started with like stakeholder engagement, teaching people, telling them about, well, some of the basics, why interoperability, why do we need it, and how can you do interoperability without having just one solution, because that's not really interoperability. And then on the bottom picture is basically the outcome. It wasn't planned at the beginning of the project, but we were planning after the mini connectathon, which I will talk about in the next slide, which was testing of the 3 solution providers, sending data between each other. We were supposed to do operational testing, and we were waiting for approval from the Ministry of Health to start exchanging real data. There's a bit of processes, data protection agencies and stuff. And then it was elections in Senegal, and then it was impossible to do anything operational. So we pivoted, and IHE Europe reached out because they were curious about this crazy people doing IHE in Senegal where there's no architecture. And then they said, yeah, why don't you send the companies that went through this mentoring process to the next Connectathon that was happening in June in Italy. And there was another round of mentoring because it takes a little bit to start the registration process for Connectathon. But basically, we managed to have the 3 first African companies participate in the IHE Europe Connectathon, and they won some of the seals or the certification for some profiles. And so a Connectathon is basically, in the IHE sense, it's a meeting of about 100 software providers, and they've all come with a list of profiles that they would like to certify, and they've registered on that software platform. And then over like 4 or 5 days, there's like testing going on, and then there's people with blue shirts that are monitors that are like verifying the transactions. So it's a very buzzing, very nerdy environment. Like definitely lots of Coca-Cola and pizza going on there. It's not a software development meeting. It's a testing and verification meeting. So you've already tested your solutions. It's already been tested against like online validators, but now you're testing it against other software and other implementations. And of course, like you might find bugs. So it's a bug fixing and certification meeting, but it's not where development happens. Sometimes some Connectathons have been about developing interfaces and things. And so like, just like to mention the mini Connectathon that we did in Senegal, which was much smaller, but in a way we used the same standards, and most of them were Fire-based, like PixM, PDQM, MHD. They're all like Fire-based. And you can see on the bottom right, so we didn't use the IHE official tool for testing, which is called Gazelle. But we used a simple Google Sheet, and then all the test protocols were recorded at Google Docs. But we followed the same methodology for the testing because all the documentation is available. And so the 3 providers were able to like validate the 8 profiles that were identified. And basically some of the profiles, I don't want to go too much into detail of IHE, but some of the profiles are, for example, profiles that allow you to, if you are a hospital solution and Richard is another hospital solution, and I want to find out if a patient has a record in his solution, then I send a request to his hospital. And sometimes there might be mistakes in the name, so there's probability involved and things like that. And all of those are specified in the use case. And then there's other profiles for making sure that a system has the right authentication, or like have for an audit trail, that every modification of a patient record has an audit trail, so that you can find out if anyone modified a record. So really what I wanted to highlight is like, there's different concepts, tools, and goals. And I think it's important to recognize, I think Graham said it yesterday, like Fire is not the only standard. There's a lot of things you can do with Fire, but it's important to understand which tool does what and which approach is trying to solve which problem. And of course, it's a bit simplified here, overly simplified, because Fire is not just about the technical language. There's more than that with the IGs and things. But here in this exercise, Fire was like the base conversational layer, the technical standard. And then OpenHIE is like, how do you get a national level interoperable architecture based on reference architecture and some existing open source components. And then IHE can be used when you want to have a group of vendors that are certified, and to reassure someone from a ministry or from a public hospital or even a private hospital that the solution that they are choosing is going to fit nicely into the architecture that you have put up with your country. And I think, so that's my attempt of sort of classifying those. I think FIRE is really great because it allows us to do a lot of innovation, to build new services. But when you get to like the national architecture level, and when you want to have multiple software vendors, like for example, hospitals do not have to send a complete patient data in order for a doctor to have an understanding of pre-existing conditions or that a patient journey has been done. They don't need 100% of the data that's stored somewhere else. So what IHE does is it gives you the minimal requirements in order to have a shared patient records that's useful for a doctor. Or like, for example, if you want to do an electronic prescription so that you can go to a hospital and instead of them handing you a paper, you can just walk into the pharmacy and they'll have your prescription if you show your ID or some kind of identification. And so like all of those are existing profiles, and in fact, like in the Austria example that I mentioned before, and it's only one of many countries where IHE has been used for national architecture. There's examples in France and Belgium, Albania, and some other places, even in the US, like some parts of the architecture are IHE based. Like, the architectures evolved. Someone was asking me why are connectathons taking place every year. It's because national architectures evolve. And sometimes you don't start with electronic prescription. You might start just with like a patient record. And then over time you add new services, and then there's new standards, and some of them evolve, so they have to be tested again. So I think this is my last slide. So if it wasn't clear, some of the things that I was talking about in the presentation is how do we ensure a community of vendors can be created that manage a testing process or a certification process, a community in Africa. And I think this is really like key, because if you don't do this, you end up with certification processes that country governments are like pushing, and then you have one country, like Senegal has 17 million people, 30 hospitals, and if you are a developer of a vendor of a hospital management solution, you don't want to sell it only in Senegal, you want to sell it also in Ivory Coast, Benin, Morocco. And so like the more like aligned those markets are, the more similar the infrastructures are, the architectures, the better it is for everyone, because then you can choose software from different places. It lowers cost. And you're also not having the situation where every country has one vendor that's doing the architecture, or even worse, every country has one ministry that's driving the architecture, because I really don't believe in ministries digitalizing the health system. And that's like the last point, like how do we ensure that the private IT sector can play a strong role? And in a way, Africa is the last place where IHE has not really taken root yet. And there is an opportunity to like create that community. It doesn't mean that you have to take 100% of the standards and the approaches that are done somewhere else. There is a process for contextualization of standards, similar to like the extensions and FIRE. We've been in discussions, like there's been talks with Helena is setting up a standards and interoperability lab, and like testing according to some examples from AHIN in Asia. And yeah, so the question is really like, how do we get on this journey to have testing, but also to have like a market of mature vendors that can sell software in multiple locations, and not just every country developing their own approach. I think that's really like what it means. And the last point, yeah, interoperability alone does not build working architecture. Like there's like interoperability is the base, it's the glue, but it's only one piece of the puzzle. Like, if you have an interoperability-based architecture, it doesn't mean that you're gonna have hospitals that are digitalized effectively and that doctors are gonna use solutions. So I think we have to also remember that there is a bit more to the discussion than that. Yeah, thanks.
Thank you. Yeah.
Thank you very much for the wonderful presentation, which is a different flavor to actually show how the private sector can contribute to the overall health goal of a nation. I want to ask, I have got two questions. We have been introduced to IPS, and we know how the IPS is working. And I want to ask if you tried IPS, maybe instead of IHE, and also the global health GDICN certification network. Have you also tried to use it to sort of certify the different systems from the private sector, so that you come up with an assurance? What were you using? You spoke about assurance, but I'm wondering, what were you using? Were you just using, just the connector tones and then gut feeling? My worry and my question is, if a private player comes up today and they want to also do what other private players did, so that they could also just connect objectively and not subjectively, how will they do it in this network? Thank you.
Yeah, thanks. So the easy answer is no, we did not. But like IPS is also an IHE standard, so like it's collaborative development. And regarding the second question, so what we did was we selected a few of the profiles that we know are key when you want to develop an EMR system that's based on the idea that there is a central registry and several places where data is produced and consumed. So we operated in a black box because our goal was to demonstrate, hey, you have the opportunity in this greenfield environment in Senegal to build an architecture that's going to leverage your existing solutions. And here's one way to do it. If our goal had been to develop the architecture that will be able to do that, we may have done a different approach in starting with the architecture. I think that's really the next step that needs to happen now in Senegal. And there's a World Bank project that's injecting some money that's going to drive some of those discussions. And I think for that, the next step would be for the government to agree, what is the architecture? Is it an open HIE architecture? Where does IHE fit in? Which standards are going to be used? Some places start with that architecture document, some places start with an interoperability framework. And then that's when the vendors know where they're going to align to. For us, what was important to demonstrate to the government is that there are approaches that you can use in order to develop that architecture. And the worst idea you can have is either to go something that's only one system, or to develop a completely custom architecture that only Senegal has, and that's like developed on Senegalese standards, so very specific adaptations. Because then what you do is basically you're walling it off, and again, there's only a couple of vendors, or in some cases only one, and that's high risk for the government. Yeah, we didn't solve unique patient identifiers. I think the way that it was discussed during some of the workshops was to use a mix of the names and date of birth. There's an identification card in Senegal, which is like a national ID that could be used for like 95% of like the population, and then for the other 5%, you have some fallbacks regarding the names of the patient and names of the father and mother to identify the patient. I think that's what was discussed. But again, it was not really the exercise, because that's a process that really needs to be done in conjunction with like the different government instances in the country. IHE provides certain ways to do identification, and then there is matching of patients. There is some profiles that are able to do matching of patients based on rule sets and probability matching in order to allow for people mistyping names and things like that. In a way, like I didn't want to go too much in detail, but usually when you do start an implementation with IHE, then there is a projectathon in country where a lot of those country-specific things are discussed and decided. But like the IHE model does not prescribe how are you going to match patients. I mean, that's something that can be discussed in country, because like there are several techniques to do that, and you can use weights to decide which fields are going to have precedence for the matching algorithms.
Any other questions? Yeah.
Thank you. I am Ramadan, like Ramadan. I'm from Ministry of Health of Tunisia, and I don't really share your opinion about HIE fire HLZ. Fire HLZ have many functionality, and you talk about security. That security is transversal functionality. Any framework can do this. And if you want to limit some data to be transferred, you can use like this functionality I'm talking about. Because sometimes there is business logic aspect in development, and functionality of fire is good, like APA. Any APA is not secure in the beginning of it. That's I want to say. Thank you.
Thank you very much. So in a way, like I've heard over the last days, there's a lot of different schools and perspectives, and I think that's completely okay. Like there's different ways to do different things, and I think like I hope Graham will have a chance to come in, because I would love to hear some of his views on this. And if you have fire-specific questions, he'll definitely be the best to answer them. I will not try to answer fire questions in front of Graham. And like what I can assure you is that security is taken very seriously within IHE. There's like dedicated profiles for ensuring data security, because again, the origin of this community was vendors that were niche and usually not the biggest ones, coming together to demonstrate that their software is more mature and is mature enough to fulfill a role. And in health, you don't have a choice, but security has to be one of the key considerations. And so it's taken really seriously. And if you have specific questions about IHE and data security, I can give you the contact of one of the people who did the verification of the profiles on that aspect, because he would be much better suited to answer those questions.
All right. So maybe on that note, maybe we will hear from Graham, give us some reflections, and put this into the context in terms of fire in the world, or kind of interoperability in the world.
Hey everyone. So I support fire implementation in lots of countries. You get dragged into their arguments about how to do things in lots of countries. So here's a few of the things that I've learned. The first thing, I joked last night about what FIRE stood for. Some of you heard that? Fixing HL7's international reputation. Here's the joke about what IHE stands for. Interoperability in hotels and exhibitions. And look, it's a bit true, and it's a hard lesson, because when you think you've got people to agree, you haven't really. It's only when the computers agree that they really agree. And it's just hard work. And there's no easy way to do this. That's the first thing that I've learned. And trying to railroad the process to make it go faster will make it go slower. You just won't realise it till later. And so this is just, it's hard. Now, Richard started by asking, what's an HIE? And that's a really interesting question for me, because there's kind of three models for what an HIE is, for me. The first idea of an HIE is a big shelf on the wall where everybody files their stuff, and then nobody looks at it, because it takes too long to look at it. And there's all these words about how useful it is because they've got all the information from all the institutions in the one place, but that is the actual problem. All the information is in one place. And so people look at it when they really, really have to, but the clinical staff really don't want to do that because it's such a low yield operation. The second model for what an HIE is that when you rock up an institution and all the institutions in the HIE, all the information they have is transferred to where you are. Well, that is harder than just filing stuff on the wall. The problem with that is institutions don't trust each other. If they trust each other, they don't have an HIE, they have a system. And because they don't trust each other, they don't really want all the information. They just want the highlights. But nobody agrees on what the highlights are because it depends on the case. And so you get more, but it's harder to get, and no one is really happy with that. What makes people happy is when they can share work contexts. Not just move information or store it or move it, they can actually share their work. They can make bookings on each other's systems. Patient can bounce backwards and forwards, seamless care plan. That's the hardest of all. Harder, but that's the only thing that'll make clinical staff happy. That's my experience with working with this. So an HIE is a good idea and a necessary idea, but nobody's ever going to be happy with it until you get to seamless interoperability, which nobody's ever seen. So, it's a really good question Richard asked, is what is an HIE? And I'm not saying that you shouldn't have one, because you've got to have something. What I'm saying is, nobody will ever be happy with you, even when you win. And just go in expecting that. And that's another thing I've learned doing this is, when I first started doing interoperability in Australia, when we decided to connect two hospital systems together with the HL7 version 2 ADT feed, that would be a major project. We'd need lawyers, we'd need contracts, we'd need support staff, we'd need development time, we'd need a test system. Today, we just turn it on. And when it doesn't work, we're surprised. And yet everybody says that we're not better than we used to be. Interoperability is still hard. And the thing is, interoperability is a people problem, and we still argue, but we're arguing about stuff that's an order of magnitude harder, while the stuff we were arguing about is just nailed, done, solved. We're always going to be unhappy about this. We'll just be unhappy about something harder. right? And it's just easy to feel, particularly for people who spend money on interoperability, to feel like they're not getting value for money. And so a big part of this is managing expectations, because in my experience, in every country I've been in, creating an HIE or spending money on connecting systems together is first and foremost a political choice. Politics. They spend the money on us. So what are they getting for their money? So a great characteristic of a politician spending money is they want outcomes in 18 months. And there is no outcomes in 18 months in this space. It doesn't happen. You need longer than that. And that's a huge problem I haven't figured out. You can laugh at US politics. I do. USA is a stupid country in lots of ways. But the government can spend money in a sustained fashion over decades to pursue healthcare interoperability. It's just about the only country in the world that can, maybe the Dutch. Right? It's hard. And I often say that the characteristic of Australian farming is 2 seasons of flood followed by 15 seasons of famine and drought. And then the cycle starts again. And that's how healthcare interoperability works in Australia too. We have 2 seasons of flood where the minister throws money at interoperability, and then we have an election, and we have about 4 cycles of government with nothing, and they wonder why they don't get anything. But this is just reality, right? We can't change that. So that's the context in which you operate, and there's no point wishing it were otherwise. What we get to do at our level is try and create continuity and create capacity so that we can get progress. Because as I said, even though it feels like you're not getting progress, you're still getting progress, right? And then one thing I've learned, going back to the HIE question, is that institutions keep records for institutional purposes. They don't keep the records for the patient. They keep the records for their own legal liability, for their own performance measures. They pay to create the records, and they're paying to create the records for themselves. If you want real interoperability, you have to explain to the institution in a way the CEO can't ignore, or the board can't ignore, or the government department can't ignore, why doing this interoperability will meet institutional purposes. There's just no other way. Institutions defend themselves. That's what happens. And then the other thing that happens is you head off, you've got money, you've got a clear mission, you've got a deadline that's about 3 years too early. I've lost count of the number of governments who've said we're going to have this in 2 years. And I'm like, no, it's a 10-year project. There's no getting around that. It's going to take 10 years. But you've got your money, you've got your deadline, you've got your team, you've got the political will for 2 years. Go for it. What happens is that you've got that deadline just right in front of you. It's terrifyingly close. And so from day one, you make compromise after compromise. The project will succeed, but die at the death of 1,000 paper cuts. You can't help that. So your job as the people doing the actual work is to try and make the short circuit you have to take, not to protect the fundamentals as much as possible. And remember that as you go into these projects, the project will fail. It will succeed, but it will also fail, and no one will be happy. So don't let yourself get distracted by that. Because, a beautiful quote from this morning, if we do it by ourselves, we'll do it fast. If we do it together, we'll go far. And I think that if we do it right, as much as right can be, next time we'll get further, and we'll get further, and we'll get further. So I don't want to depress you. I just want to set your expectations, right? This is a people problem. And this is what I've seen all around the world. But I have seen this. If you want to succeed, to get as much success out of a project or a government or a funding cycle or whatever as possible, this is the 4 things you need. You need a national strategy that makes sense so that people know where they fit. The strategy, if you don't have a strategy, like in Australia for years, we didn't have a strategy, no one would spend any money because they didn't know where it was going to go. No one would do anything in fundamentals. So you need a government strategy and policy to support it. Yes, it's always compromised by politics, but a government can still have one. A government should still have one. If you're a government person here, I encourage you to have one because it's a big part of the success. The second part of success is workforce capability, having people who can do the work. If you don't have the people who can do the work, you can't do the work. Doesn't matter how clever everything else is, you need the people. The third thing you need is an NGO of some kind. It could be OpenHIE or IHE or HL7 or Helena. It doesn't matter, but to have an NGO to do the actual spec development, to support the community so the community can have open discussions. The politicians set the direction. The bureaucrats set the goals and the scope, but the only people who can say how things actually work are the people doing the actual work. And how do you bridge between the scope and the workers? And you need an NGO for that. We tried in Australia. The government wrote the specs. As soon as there was a mistake in one of the specs, it was a briefing to the minister within 30 minutes. It's a political disaster. You need an NGO to let the community have an open debate and insulate the government from technical mistakes. All right? Massive importance. That's the third thing that you need, is the NGO to do that. And the fourth thing you need is connectathons of the various kinds that exist so that vendors can turn up and make mistakes without any cost. No mistakes, no progress. It's that simple, right? So for me, if you want success, those are the 4 things you need. A government strategy that makes the least sense, workforce that can do the work, an NGO to assemble the community and let them argue, and connectathons so that companies can actually try this stuff and make mistakes. Because if you make the mistakes in a real project, your managers and your salespeople, relationship people, they just double down and go to the ends of the earth to prove that you didn't make a mistake, instead of just fixing the mistake. Right? So connectathons, really critical. And the other thing I want to tell you is that what works is top-down management with bottom-up. There needs to be somebody running this that the local community respects and believes in. They have to believe in at the community, at the political level, and they have to be believed in at the companies and in the NGO. That person. In Australia, we have a woman named Kate Eberl. Has anyone here met Kate? She's kind of high profile. Kate is awesome. And she is the secret of Australia's success right now. And when I look around the world, I see the same thing. There's a person whose personal reputation is on the line, who is the person who everybody respects and can make it happen. I don't know your countries. Maybe some of you are in this room right now. You are that person. And if you aren't, stand up. And the thing that you need is recognized technical expertise. You don't tell lies or make stuff up. When you say something, people believe you because you're right. You need to be not subject to any particular interest, and it needs to be a career so people believe that you think that in 10 years you're still here and it matters. That's what makes people believe in you. So if you are that person, remember those things. Don't make stuff up. Know your stuff. Stick to your guns. Tell the truth. Yeah, I tell you about me. So the Australian government did some things that didn't make sense. I did them for the Australian government, and then I turned around and said, they weren't such a good idea. Death by 1,000 paper cuts. The project went live. Started getting criticised in the media. The government came to me and said, we want you to explain to the country why this is a really good idea. And I'm like, sorry, it's not really a good idea. We really need to say it's time for us to make it better. And the politician said, no, we didn't make any mistakes. It's time for you to tell the country it's right. And I didn't do that. Instead, when I was asked, I said, no, it's time for us to make it better. The politicians couldn't go after my funding because that comes from USA. They couldn't go after my expertise because I am the international expert. They really don't like me. I had to wait 10 years for that to blow over. Right? But it's worth doing that. So if you are that person in the room for your country, stand up, have spine, and you will really make a difference in the long term. That's what I wanted to say. Thank you. Any questions about that? Yeah.
And that will be part of our elevator speech when you get back home and when you're trying to actually convince. The work you did in Australia is tremendous, and no one can fit your shoes, but we can try to fit your shoes in our own countries. But I can tell you, and I have to tell you, that it's tremendous. I'm coming from Zimbabwe. I work for the Minister of Health, and I'm the head of ICT. So I can say it's really, really tremendous. And these are lessons learned. Would you just mind penciling them down? And then as a take home, I think I'll be enough. I can go home right now if you give me those things.
Thanks. I will work on mine. What I said bore a little bit of resemblance to my notes. I will clean them up, and how do I send them to you, Fred? How does this work?
Yeah, that's a good idea. Yeah, we'll keep a kind of a community, so to speak, that we can reach,
Okay.
get in touch with people. Yeah.
We'll do that. Yeah.
We're going to share out a lot of the videos and all the slides and other things like that. So
Oh, hang on. Did I say all that in public? Did I?
I'm not sure, you might have. It's all right.
It's
not-
a little
we're
bit
not-
about a little bit about the Australian. Maybe
We're not
we
the
could take
stream.
that
We're not
out.
streaming. So yes, that's why it's not streaming.
Yeah, yeah.
So.
We take out a little bit of there about the Australian thing. I don't want that to blow up on me in Australia.
Any other comments or questions?
You can also
Maybe-
ask Richard and Niels as well. It's not just about me.
Yeah. Maybe I'll ask a question actually. When this is something that actually Richard and I were also discussing. Like I think what's interesting to me in this kind of architectural stuff is, we see there's a lot of people starting to build with fire, right? So, and as you say, people make problems, it's not technology. The technology's there. Fire forces us to think about things like terminologies and others. And we often, we have this idea that, well, if we just use a standard, we'll kind of get a better result in terms of, we won't have these like siloed systems and data will just flow. But it seems to me that it's very possible to kind of, commit the same crimes, but just using standards. So how do we think about, I suppose, trying to avoid that, right? Like, is it that there needs to be the policy and other things in place first before it makes sense to be adopting it? Or is it that, there are ways in which once there is those implementation guides, let's say within a country, that we can then, use the standard and the tools that are out there to kind of migrate towards that, so that by building to the standards, we are actually like future-proofing some of the work that's happening, and it will be easier to kind of create this, interoperable world when some of those other pieces are in place.
So I'll go first and you guys can comment. So first of all, there's absolutely the fact that we are getting better and we're moving ahead, and each year it's easier to connect things up. One thing you said made me think something I meant to say, which is that if you put together a clinical system with a bunch of users, the first thing those users do is they figure out all the workarounds. And then they have their own secret knowledge, their secret culture about the system that they're using. As soon as you hook it up to another system and do interoperability between systems, then this system here's set of secret knowledge is about to run head-on into this system over here's set of secret knowledge. I joked the other day, I was in Lisbon. In Australia, About 5% of people are born on the 1st of January 1901. In the institution that where I first worked at, because that's what you put in the system if the patient didn't give you a date of birth. 1st to the 1st, 01. Everybody knew that. Then we got hooked up to another system which blew that system up because they were like expecting everybody to be, you know, 80, 90 years old at the time. Secret knowledge, right? As soon as you hook up systems, there's secret knowledge, you're going to run into each other. The cardinal sin of interoperability is not to be ready for that. It will happen. When we first gave everyone an access in Australia, we gave everybody access to their government billing record. Then we had people in the media going, I'm a man, why did I get a pregnancy test? There were a few reasons for that, but fundamentally we didn't care about the quality of that data. If the government approved paying for it, then it was fine. And that was another example of that. So when you hook up systems together, be prepared for there to be safety problems. Be ready. In fact, basically being ready is kind of what I was talking about, right? It's not going to go great, so be ready for that. But back to your question, we can share knowledge and share projects, and Helena could be really great to buffer the whole community against funding cycles, because, you know, Helena's not subject to any single government. So it could be really good in Africa, as is the role of OpenHIE and HIE and HL7, and we can all help with that. And I don't, maybe I sounded a bit negative, but I'm really optimistic. Things are getting better, and we can just keep doing what we're doing with, and the energy here, this meeting is amazing. I'm loving this meeting, and I'll stop there. Do you want who's going first?
Yeah, thanks for that question, Fred. I don't actually have a solution to your question, but from my experience with some of these implementations that I've been involved with, is that countries dive into, let's implement FHIE, let's create a shared health record. You've got systems already, they're kind of siloed systems, they're capturing this information already, but then you have some implementer saying you will implement a shared health record. I'll be like, why? You've got information systems that can capture this information. Why do you want to duplicate this in the shared health record? Why? No, I don't know. Just because. That's not an answer. They don't actually really understand what they want to do with the data. You know, going back to policies. When I ask countries, so what is the country actually saying when it comes to data sharing? Do you actually need this? Do you have policies that says what should and what should not be happening from a government point of view, from a policy point of view when it comes to data sharing? They don't have that. It's either fragmented or it doesn't actually really exist. There's been some countries that's been involved with the Data Protection Acts. First it must be applied, then it mustn't be applied, then they're not sure. There's not the right people to advise if data of a certain nature can be shared or not. So by the end of the day, we have this HIE that's been established. Whether it's appropriate or not, I don't really want to say. It's very, very challenging. So I think going back to the strategy level and the government buy-in, that is two critical components for me. I think where things should be the underlying kind of framework that says at a national level, this is what you should and should not be doing. Implementers should adhere to that as a basis of rules, as a framework, in my opinion.
Yeah, and I think maybe what I can add, pretty much the underlying, when we started the project I presented, we knew there's two ways to go about it. And that's pretty much what Fred described. We could start with the policy and architecture conceptualization, or we could start to demonstrate some of the interoperability. And we chose to do the latter. And I'm actually really glad we did, because like when I tell the story, people listen, because, and sometimes in a way, I wish it wasn't me telling the story today. Like originally, Fred and I had discussed to bring like some of the providers that we have trained in Senegal so that they could share the stories themselves, and that would be much better. It was a bit challenging logistics, so like it's me instead. But I think like they are the agents of change. I mean, we are a catalyst that helped building some connections and bringing in some expertise from people who have been doing this for a while. But as I said in my presentation, it doesn't mean that it has to be done the same way. About their own architecture and how do we maximize the similarity and ensure that there is a small piece that's different, because everywhere things are slightly different. But in a way, we're all humans, and we know that the records about us are 95% similar.
Can I add something, Fred?
Okay, just short comment. And
Okay, sure. And as we start thinking about some of these challenges, and something I've experienced over the last 2 years, and first of all, how many of you, by show of hands, have either started implementing FIRE, have implemented FIRE, or in the process of implementing FIRE in some sort of way? Can you just raise your hands? And can you raise your hands if you are a developer who's actually doing this? Okay, great. How many of you have actually implemented an implementations guide to support your exchange? So, great. So this is actually something I've experienced over the last 2 years. It's that, so it's not so much FIRE, while it can be very technical to understand, sure, it's that the clinical to technical translation. So what that really means is, as you have your data requirements established, you need to understand where you're going to put that data, how you get, well, which are the appropriate FIRE resources to capture this information, because each resource has a very specific meaning in FIRE. So what I'm trying to say is I've seen some implementations where some implementers have translated or kind of interpreted data requirements. Let's put this into this resource. Another implementer will do it differently than another resource. So one is right, which is clinically appropriate, while the other one is not. I've seen some instances where there's been smaller FIRE ecosystems, and they start talking to a larger national ecosystem, where there's an implementation guide, national data dictionary, some profiles implemented. This is the right way to do things. Now there's one small ecosystem that says, okay, I'm doing this right, so I can actually communicate with this national exchange. But then we have another one or two or three that have done it completely different. They're using the wrong resources, wrong data elements. Now the country's going to like, now how am I going to solve this problem? So what I'm trying to say is, if you have the luxury of a subject matter expert, try to get hold of this as much as you possibly can to help validate the appropriacy of your work, of what you're trying to do, as much of the extent as possible. And implementation guide. Start off there. Don't start off with your payload and try to reverse engineer into implementation guide. Believe me, I've seen it. I'm supporting some work at the moment. It can change everything. I mean, everything. And think about 2-3 years worth of work and data warehouse, pipeline. It's a nightmare. So, yeah, I just want to mention that.
Great, thanks, Richard. So I'm going to invite Dr. Olegas from Lithuania to share some maybe thoughts from their experience of implementing FHIE or achieving interoperability? I voluntold him.
Thank you, Fred. My name is Olegas. I'm coming from Europe, from small country Lithuania, and actually next year we're going to celebrate 10 years of using FHIE as a national standard to exchange data on national EHR. Well, it's difficult to add something. Everything was said today, and we had three beautiful perspectives. Richard gave perspective on the essence of interoperability. Nils gave us the idea of platform of using standards in a kind of team way, right? Team play, what HIE provides. And Graham gave us, I would say, very practical aspects of wisdom of lifetime. And for me, recapping our journey of Lithuania, just in a few sentences, interoperability isn't a project. It's not initiative, it's a journey. And basically what we learned applying FHIE, HO7 FHIE, so there are many ingredients in that soup which you need to take care about. So what Richard was saying, for me, that's something what you need to take care in your universities, but your health informatic guys understand that. Second thing, what Niels was saying, for me, it's a kind of a team play. So imagine your interoperability projects like being in one boat. And basically in this journey, you want to have people like-minded, who look the same direction, and ideally have activities which bring you to the same destination. And third thing, what really I liked from points which generously were shared by Graham, is the idea of a leader, local leader. The reason is that politically, in most of the countries, you have different schools of thought. We need standards, or standards are too difficult, or there are shortcuts, not do that, or not these standards, or no IGs. It's too, let's do it quicker way. And in that situation, you need to have a leader. And this leader doesn't matter political, but should have a voice and ability to speak up. And hopefully this leader would follow everything what was taught today. So in Lithuania, often we don't have this kind of a leader. So our way is a zigzag in many ways. So feel free to come and I will share in secret over mistakes we've made during 10 years. But however, we do have a success. We have a working system with all referrals, prescriptions, discharge summaries on national scale. So colleagues who are starting this journey or beginning it, I want to encourage you, and participating in this event, it's a fantastic way to guarantee your success. Thank you.
Thank you. Thank you. I like that analogy that it's a journey. So, maybe as Graham said, the destination will always change, really. So buckle up and, really, you got to love the journey that interoperability is, because there's a lot to learn, there's a lot to apply, things will change and they'll keep changing, but it's about having that vision of where you're trying to get to. So I think with that, I think we can wrap the session. Any final questions? Great. Thank you very much, everyone.